nutrition, and then you do some assessments if the patient has fall, and then you need to review the medications. What medications? TCAs, benzodiazepines, antihistamines, even antihypertensives, they can contribute towards fall. So if the patient comes to you with a fall, then you will do this, and you can screen the patient for fall in both the scenarios. You can use the same sequence. Postural hypotension we discussed. Gait disorders. To assess to give the intervention, you can ask the patient to use assistive devices, strengthening and balance exercises. So physiotherapy is very important in gait problems. Impairment in the leg arm strength, so resistance exercises it's going to be important. Vitamin D supplementation is also going to give good benefits in those patients. Hip protectors if required. So environmental assessment is also very important. We were doing it, the individual assessment. Now you are going to concentrate on environment. Is there is a proper light in the home or at the patient where the patient is living? Is it proper or not? Handrails are present or not in the washrooms, in the washing areas. So proper support system should be there in the houses where the patient is living. So you need to assess, address and counsel the caregiver. Bathroom mats. So there should be a bathroom mat so that the patient does not slip away. What complications can occur? Obviously, if the fall happens, it may have fractures, maybe subdural hematomas, dehydration, electrolyte imbalance, pressure sources, fear of fall and immobility. So these are all complications of fall. So fall is a very important identity. If that happens, when you go into your primary healthcare center, please ask these geriatric population one or two things, and please try to implement only one or two scale. You should not do the whole screening on this one geriatric population. He is going to get annoyed. But if an elderly patient coming to you, you just take the history. He's just here for the medication refill. He does not want anything from you and just the medications. But you as a physician and as a learning tool, you can just ask, okay, I was just wondering, you take your medications regularly by your own self or not by one geriatric patient you may assess only ADLs. One geriatric patient you may assess only IADLs, outside activities. If one geriatric patient comes to you, you can just ask him, if you don't mind, can I do one test so that it can help me up? Get up and go test. So you ask the patient just to do get up and go test and make your assumptions, make your diagnosis, observe their behaviors. Maybe you can do abnormal mini cock test on one patient. So just just practice these random tests on them, one or two, so that you will also have an idea that these are the very important issues that are there, and no one is addressing these issues. So if you have the chance, please try to incorporate these practical tools into your history taking while you are rotating in the primary healthcare centers. So this is fall. Now we talk about dementias. What is the difference between dementia and deliriums? Dementia is, yes. Delirium? Delirium is acute. Yes, number one, delirium is acute. Dementia and delirium. It would be difficult to differentiate between cognitive and what else you mentioned? Consciousness. Loss of consciousness and cognition. Usually it is very mixed kind of a picture in dementia and deliriums. The one differentiating point is acuteness. And the other differentiating point is reversibility. Usually the dementias, they are progressive. Deliriums, they acute and they can reverse. You can reverse these dementias. And dementias, what are the secondary and primary causes? We will see that. So in dementia, if the patient is having dementia, you need to assess again the medications, the functional assessment. Warning signs: inconsistencies in the medical history, word finding difficulties, confusion about the medications. So these are the clues that the patient may have dementia. Not the clear-cut dementia, but an impending dementia. Because remember that you are in an outpatient clinic. You cannot just see a completely confused person in an OPD setting. You need to assess these occult signs, inconsistencies, word finding difficult, confusions about the medications. So you may think that probably he is having dementias. The causes are Alzheimer's is the most important and most common. Then we also have vascular dementia and Parkinson's disease. The things that can mimic dementia, depression can also, you think that it is dementia. So you need to differentiate. Sometimes the patient is on benzodiazepines, so the drugs can also mimic as dementia. Hypothyroidism can also mimic as dementia. Yani B12 deficiencies, deliriums can also mimic as dementia. So you need to diagnose the patient, you need to act on fall prevention, nutritional support, all these assessments that we discussed, you are going to give these patients with dementia. These are some of the medications that you can use it to decrease dementia. So we discussed about, I'm just concentrating on the important things that are relevant, actually practical aspects, because geriatric is a whole specialty and I don't want you to go into much of details of things that you are not going to apply. So we will discuss those aspects which is good for you and which you can apply. Yeah, just one thing and then we will have a break after 15 minutes. So dementia, and we were talking about dementia and deliriums, right? Dementia is a progressive, irreversible, multiple cognitive deficits, okay, which interferes with day-to-day activity, marked by decline in functioning, characterized by change in the personality and behavior. Dementia, if you see DSM-4 criteria, memory impairment, at least one of the following: aphasia, apraxia, agnosia, disturbance in one and two of the interfering daily activities, does not occur exclusively during deliriums. Other symptoms can have psychiatric and behavioral problems. Risk factors we discussed. If you see here, Alzheimer's, one of the causes of dementia, about 2/3, it's a gradual onset, okay? And if you see multi-infarct dementia, memory loss with focal and motor signs. So if there is loss of memory with some motor function involvement, you can see vascular problems. You can think of vascular problems, but if there are no motor deficits, sensory deficits, then obviously you may attribute towards Alzheimer's. Dementia with Lewy bodies, dementia plus early motor signs that progresses. There are other causes of dementias, just skip that, no problem. Now some words about delirium. So we discussed dementia and some of the causes is a progressive problem, irreversible problem, The differential diagnosis is Alzheimer's disease and all that. Delirium is what? Disturbance of consciousness, same. Change in the cognition that develop over a short period of time. That's different. It can be evident from the history taking and examination. It's an acute onset and fluctuating course. In dementia, you do not have acute onset, number one. Number two, in dementia, you do not have a fluctuating things. Inattention, disorganized thinking and altered level of consciousness. In deliriums, FOT factors, use of physical restraint, use of bladder catheter. So these are the medical conditions that can cause dementia. So that's a reversible problems of factors of dementia, like infections, like cardiac problems, respiratory problems. So all the respiratory problem, all the infective problems, all the electrolyte imbalance, endocrinological problems. So all the medical issues you are going to evaluate and exclude all these medical problems while you are addressing delirium. What I would like you to develop is understanding of your concept of, am I dealing with dementia or delirium? Number one. If it is delirium, then you need to exclude all the medical reversible causes, electrolytes and all that. You need to evaluate that first, and then if you are evaluating dementia, you need to see whether am I doing Alzheimer's, am I dealing with Alzheimer's, am I dealing with multi-infarct dementia, Lewy body dementia. These are all the advanced things. You just have an understanding. You cannot diagnose these things. You can do a referral, and that referral you will notify or document why you are referring. We discussed about why you are referring, what point you want to evaluate. So if you are referring delirious patient to a psychiatrist, he is going to shout on you because he is not going to treat UTI, he is not going to treat any infections. But if you are referring an Alzheimer patient to an internal medicine or a general medicine ward, then he is also going to shout on you because this is your wrong assessment. So in terms of assessment, you should be very clear, what am I dealing? But in terms of diagnosis, you should need the specialist input on diagnosing those things. Maybe delirium, if you think that the patient is delirious and you do urine DR test and it comes out to be positive, so you can treat UTI, and you can treat UTI, and at the same time you can also refer the patient to the internal medicine ward for further evaluation and management. That's fine. So you need to just develop your understanding of delirium, dementia and some of the differential diagnosis and how are you going to manage it. Not in very much detail of delirium and dementias and things like that, which is mentioned here in these slides. Depression, we have words on depression also, just simple. We are not